Hi, I'm Dr. Kfir Ben-David. I'm the Director of Bariatric Surgery here, and thank you for listening to our seminar with regards to the University of Florida Weight Loss Surgery Center. Before we start, I'd like to talk a little bit about the definition of obesity. Obesity is a major problem in the United States, and the way that we defined obesity is by your body mass index. Your body mass index is defined by your weight in kilograms divided by your height in meters squared, and depending on what number you get, you can be classified as either healthy weight, overweight, obese, severely obese, or morbid obesity. And the ones that I'm going to be concentrating on are the patients that are considered severely obese and morbidly obese. In the United States, since 1985, obesity among Americans has increased tremendously. You could see from the graph that as I go through the slides that in 1985 and moving up to 1997 to 2000, and most recently that we as a country have become bigger and bigger and fatter. The fattest state is still Mississippi, with 29.5% of their constituents being morbidly obese. Colorado is the leanest state, and here in Florida we fall somewhere in between in the southeast. One of the things that we have to consider is that there's a lot more patients that are older than the age of 65, and a lot of them are from the up north where the states are a little bit more leaner. Having said that, it appears that patients between the age of 18 and 65 are still considered morbidly obese, and we have a good proportion of them, and we fall somewhere in between Georgia and Mississippi. In addition to obesity, there's also a race and ethnicity distribution amongst obese patients. And as you could see, that black non-Hispanics are affected by this disease more often than the white non-Hispanic, followed by the Hispanics. So morbid obesity is an epidemic. It is estimated that at least 300 million people are thought to be obese worldwide. By 2015, 2.3 billion adults will be overweight, and more than 700 million will be obese worldwide. Again, morbid obesity is a major epidemic in this country. In the United States, obesity among adults, children, and adolescents has markedly increased regardless of their gender, age, ethnicity, or educational level. In every state, more than 15% of adults are obese, and in 9 states, over 30% of adults are obese. There are about over 72 million Americans in the United States that are obese. That equates to also having about 17% of children ages between 2 and 19 that are also obese. Here you could see that obesity also correlates with diabetes, and as you could see by this graph of the United States, that morbid obesity equates to diabetes as well. And you could see that the counties in the top bottom 2 quintiles of both diabetes and obesities. And if you remember from the previous slides, that is equivalent to the obesity trends throughout the United States. So this is a costly condition. The annual cost of this obesity is as high as $147 billion a year. Obese people have an average annual medical cost that exceeds about $1,500 more than people of normal weight. About 45,000 patients die each year from morbid obesity before retirement. And there's an indirect cost and a direct cost of being obese. There's about $4 billion a year of indirect costs. There's about 40 million work days lost per year for patients that are morbidly obese. And as you can see, the medical cost that is required to take care of obese patients is significantly higher than those that are of normal weight. The cost of obesity, again, is about $123 billion a year. That equates to both a direct and indirect costs. We spend about 9% of our total annual medical care expenditures are related to obesity. So fat for life, this not only affects us, but it also affects our children. As you could see, this is hit Streamline News and Newsweek. 6 million kids are seriously overweight, and that number is continuing to increase at astronomical proportions. The prevalence of obesity among boys aged between 12 and 19 by race and ethnicity has also increased, and you could see that non-Hispanic blacks have increased, and especially the Mexican Americans that have increased when you look at the different time periods between 1988 and 1994 and 2007 and 2008 as depicted by the figure. Similarly, females are also affected by this, and in similar proportions, non-Hispanic blacks are also increasing at tremendous growth of being obese between those two same time periods. Childhood obesity in this country is a major problem. 1 in 5 children in the U.S. grades K through 8 are considered to be overweight or at risk of becoming overweight. This is enough to fill 12,400 elementary schools and enough to fill 20,000 classes. The major health organization has classified morbid obesity as a disease, as does the National Institute of Health, the American Medical Association, the National Academy of Science, the Center for Disease Control, and the Association for Endocrinology. So what is morbid obesity? Morbid obesity affects a lot of our body parts. It affects our mental health, cardiovascular system. It affects our endocrine system, especially if you gain 11 to 18 pounds, double the person's risk of having type 2 diabetes. It also affects the reproductive system. There's higher rate of sexual dysfunction. It also affects our respiratory system. Most patients that are morbidly obese also have what is called sleep apnea, which require them to use a CPAP machine. A lot of them have a high risk of having heart disease, tendency to have more infections than normal weighing people. With regards to the digestive system, patients are at high risk of having colon cancer, esophageal cancers, gallbladder issues, kidney issues. And not to mention that with regards to their bones and their joints, they are much more likely to have arthritis than people of normal weight. For every 2 pounds of weight gain and increases in weight, the risk of arthritis increases about 9 to 13%. So when we think about morbid obesity, the likelihood that you'll have diabetes is 3 times as high, gallbladder disease, hypertension, having sleep apnea than somebody who's of normal weight. It also increases your chances of having coronary artery disease, osteoarthritis and degenerative joint disease in your knees by 2-fold. And not to mention that you have a much higher chance of having cancer, especially for females, breast cancer, endometrial cancer, colon cancer. There's also reproductive abnormalities. A lot of females that are morbidly obese are not able to bear children because of their excess estrogen. There's also polycystic ovarian syndrome, low back pain, increased anesthetic risk, and also fetal defects arising from maternal obesity. So this is a major problem in the United States. Obesity is the second most common cause of death from a modifiable behavior risk factor. It is estimated that the number of annual deaths attributed to obesity is anywhere from 100 to 300,000 patients a year. And to put it in perspective, that's more than breast cancer and colon cancer combined annually. Obesity rivals tobacco as a cause of death and disability. So as the country becomes more and more obese, I think tobacco deaths are decreasing because we're doing a great job of making people aware that tobacco is not a healthy thing for you. However, we've not done such a good job with obesity. And as you can see, there's about 400,000 patients that die each year from tobacco-related illnesses. That costs about $75 billion in healthcare costs. Whereas obesity, there's about 300,000 patients that die each year from it, and that costs the same as much as the tobacco illness. So what are the causes of obesity? Well, it's multifactorial. Some of us believe that, that obesity results in a lot of different things that affect the patient, one of them being the comorbid diseases that I've discussed. A lot of the patients become disability. A lot of them have increased cost of taking care of themselves. There's also an increased mortality, and there's definitely a quality of life issue for patients that are morbidly obese. So as you can see by this graph, patients that are morbidly obese, as you go further down on the lower part of the graph where your BMI is greater than 40, you're 2.5 times more likely to die than somebody, whether you're male or female, than somebody who is of normal weight. So morbid obesity at the age of 20 results in a life expectancy in 22 years for black males, 12 years for white males, 8 years for white females, and 4 years for black females. There's also definitely an impaired quality of life. Patients that are morbidly obese have loss of self-esteem. There's definitely depression. There's especially discrimination in the jobs, promotion, society. Obesity has been called the last socially acceptable form of prejudice in our society. The causes of obesity, again, are multifactorial. Some believe that it's genetics, behavior, and environment. But the bottom line is that it's all about energy expenditure. It's all about energy in and energy out. And the more we consume and the less we do, the more gain we weight. The environment hasn't helped either. I think in the United States, we've loved our portion sizes and we've always wanted to bigger is better. And as you could see, the difference between the hamburger sizes back in the 1950s versus what they are today, and the number of calories within our food has tremendously increased over the last couple of years. Those fries have more calories than that hamburger. Not to mention that over the years we have consumed more soft drinks than any other drink product, including milk or juices. And we always try as a society to find the easier way out. It's much easier to walk up the escalator than it is to walk up the stairs as you're going out to work out. And this is a typical behavior. A lot of patients that are morbidly obese oftentimes will have exercise equipment, and a lot of times they won't use them. They'll use them for other things, as noted in this picture. Now, there are some genetic variables that contribute to your morbid obesity. However, those are usually in younger kids that are morbidly obese. There is no gene that turns on when you become into your middle ages or in your 40s that automatically makes you obese. So what can be done about morbid obesity? So there are a lot of options out there. There are a lot of medical weight losses. There are diet, there's behavior modification, there's obviously exercising, there's various medication and psychological counselings. So all bariatric patients have worked very hard throughout their life at losing weight. Right? There's a reason why there are 16,000 different diets if you Google them. And everybody has a diet that they've tried. Oprah's tried a diet. There is the Beverly Hills diet, the Atkins diet, the Weight Watchers, the Slim Fast. You name it, there's a diet for it. The problem is not so much dieting. The problem is how do you keep the weight off once you lose it? So while I was at Duke University, we looked at 1,600 patients that enrolled to the Duke program. The total weight loss in various diet programs before surgery was 248,000 pounds. However, the total weight gain back was 325,000 pounds. And as you could see, it's not so much of a problem of losing it, it's a problem of maintaining that weight loss consistently. In 1991, the National Institute of Health Consensus Conference on Surgery for Obesity has determined that surgical intervention is the only method proven to have significant long-term impact on the disease. And the most important thing to note is that when medical interventions have failed, so dieting, exercising, and non-surgical interventions have failed, that is when surgery is an option. So what are the surgical therapies that are out there that we offer here at the University of Florida? We offer both a restrictive and malabsorptive procedure and a restrictive procedure, and I'll talk about each one of those. So the restrictive procedures, which require you restrict the amount of food intake that you take in, are the gastric banding and the gastric sleeve. The restrictive and malabsorptive procedure is often considered the Roux gastric bypass. I'll talk about each one of these. So the Roux gastric bypasses are all done here at the University of Florida laparoscopically through small little incisions, which allow you to have a much quicker recovery time and to be discharged home within 2 days of your operation. While in the operating room, we perform a new gastric pouch. It's about 1 ounce in size, which is equivalent to an Easter egg. The pouch opening is about 1/2 inch, and this is the most well-studied procedure, and it is oftentimes considered the gold standard. It's most commonly performed at bariatric centers of excellence like ours, and the average excess body weight loss is anywhere from 70 to 80%, which means that if you're about 100 pounds over your ideal body weight, you would lose up to 80 pounds of your excess weight. The adjustable gastric banding is a procedure where you inflate a balloon within the band orifice that could be adjusted via a reservoir underneath the skin. There's no cutting or stapling, and the average excess body weight loss is 30 to 40%, which is half of what a Roux gastric bypass will get you. Again, this means that if you're about 100 pounds over your ideal body weight, you would only lose 30 to 40 pounds with this type of modality at our institution. The adjustable gastric banding has some significant complication, even though it's less invasive. There could be esophageal injuries, there could be wound infection, persistent vomiting. Some patients experience acid reflux, and some experience band slippage and band erosion. There's about a 20% reoperation rate of this procedure. Hence, we are not performing this as often as our Roux gastric bypass or a laparoscopic sleeve gastrectomy. The laparoscopic sleeve gastrectomy is also performed through small little incisions, and the reasoning for this operation is so we could restrict the amount of food that you're consuming. The way that we do that is we create a thin tube is created by stapling along the stomach. A part of the stomach is removed, and you lose about 60 to 70% of your excess body weight. Again, if you're 100 pounds over your ideal body weight, that means that you lose about 70 pounds of your excess body weight. It's fairly a new procedure, and there's no long-term results as much as the laparoscopic Roux gastric bypass, which has been done over 50 years now. So what are the myths and misconceptions of bariatric surgery? Well, surgery is very dangerous and should only be undertaken as a last resort therapy. And let me just talk about if you do nothing. It is estimated that the number of annual deaths attributed to obesity is 100 to 300,000 per year, as we discussed. Again, this is more than breast cancer and colon cancer combined. So what is the risk of surgery? The national data, looking at 136 scientific papers and evaluating over 22,000 patients who underwent surgery. This included randomized controlled trials. This included a large series and then uncontrolled case series. Showed that the mortality rate is less than 0.5%. That means that 1 out of 200 patients in this large database were likely to die from bariatric surgery. However, more recently, we've shown that patients who get their operation at a bariatric center of excellence, the likelihood that they'll die from bariatric surgery is just as low as having a gallbladder surgery. The Swedish obesity subject group has shown that over 4,000 patients that were morbidly obese, 2,000 of them underwent surgery and 2,000 received conventional medical therapy. This was the best randomized study with the longest follow-up. As you could see, the follow-up rate was close to 100%. What they've noted that the most common cause of death were myocardial infarction in patients that were that did not have surgery. Comparing bypasses to no surgery, the adjusted term mortality from any cause in the surgery group decreased by 40% as compared to that in the control group. The cause-specific mortality in the surgery group decreased by 56% for coronary artery disease, 92% for diabetes, and 60% for cancer. So what are the benefits of surgery? Here's a classical patient that we have that comes to see us, and they have a significant amount of medications that they take before their operation. And 1 year after their operation, they're no longer taking all these medications. One of the things that I can't show you is also what they look like before and after, and also the CPAP machine that's laying underneath the table. So there's also misconception that the bariatric surgeries are being performed way too often. So if we go back in time and we see that there's about 15 million Americans that were morbidly obese who could have benefited from surgery. And when I say morbidly obese, I mean they were 100 pounds over their ideal body weight. In 2006, we operated on less than 1% of those patients were being operated each year. So the surgery is not being performed too often, and especially not being performed too often at bariatric centers of excellence like us. And one of the remaining misconceptions is that the surgery does not last and that the results don't last forever. So here's that same Swedish obesity subject group study that I talked about earlier, showing that the patients that had no surgery did not lose any weight at all. But the ones that did have surgery, although they lost a significant amount of weight in the first year, their weight loss was significantly lower than that of the control group who was doing medical dieting and psychological counseling. And you could see that by the graphs pointed. So gastric bypass has definitely stood the test of time. There are a number of studies that show that patients have been able to maintain their weight loss as noted by all these different studies. The average excess weight loss in 1,000 patients was 60% after 7 years. Again, 60% equates to about 60 pounds if you're 100 pounds over your ideal body weight. So let me talk a little bit about the the Shands at the University of Florida Weight Loss Surgery Center. We have a multidisciplinary team approach here for your weight loss surgery. We are a bariatric center of excellence. We do have a lot of other services that are involved in your care from the get-go. You will see our anesthesiologist, oftentimes the cardiologist, our internal medicine, our pulmonologist for your sleep studies, our psychiatrist, endocrinologist, and once you've lost a significant amount of weight, we also have the capabilities of offering patients here reconstructive body contouring. Our surgical team consists of all bariatric fellowship-trained surgeons. I am the director of bariatric surgery here. I have 2 partners who are also fellowship trained, Dr. Angel Caban and Dr. George Rositas. We also have a patient-centered support group and patient-centered healthcare providers. We have a bariatric physician assistant, Mrs. Tammy Lux. We also have a bariatric nurse coordinator that helps guide you and navigate you through through the process of bariatric surgery. We have a dedicated bariatric nutritionist who will work with you before the surgery and after the surgery, Sherry Finley. And we also have bariatric surgical coordinator who will enable you to and set up we'll set up all of your appointments and we'll guide you through the process. And we also have a bariatric insurance specialist, Andrea White, who will assist you in getting insurance approval. So what are the procedures that we offer? So the 2 most common procedures that we offer here at the University of Florida is the laparoscopic Roux gastric bypass and the laparoscopic sleeve gastrectomy. And the reason that we prefer these 2 options is because of the excess weight loss that are able to be obtained by these 2 procedures. As you recall, if you have a laparoscopic Roux gastric bypass, you could lose up to 80 pounds if you're 100 pounds over your ideal body weight with a gastric bypass and 70 pounds with the sleeve gastrectomy. Now we do offer the laparoscopic adjustable gastric banding, but those are for selected patients who meet appropriate criteria. Again, you got to remember that you only lose about 30 to 40% of your excess body weight, and there are significant complications that could happen from an adjustable gastric banding. So what is the path to surgery? All patients to qualify need to have a body mass index of 40 or more, or a body mass index of 35 with a significant medical problem. We do operate on patients between the age of 16 and up to as old as 78 who have done really well with their bariatric surgery. If you're a pediatric patient who is pursuing bariatric surgery, there are additional qualifications that you need to be evaluated for, and you will be discussed this with your consulting surgeon. One of the things that in order to qualify for a first-time bariatric surgery is not to have previous bariatric surgery. You have to have documentation of weight loss from your primary care physician, which is most insurance require this. We need to have documentation of non-surgical weight loss attempts. Obviously, we need a supporting letter from your primary care physician because it's important that your primary care physician is supportive of this, as well as your family. All patients will have a nutritional and psychological evaluation. And our University of Florida Bariatric Surgery Center is composed of many other centers of excellence. So about 86% of our patients are females. The average age is about 40, and you can see we've operated on people as young as 14 and as old as 71. The length of stay at our institution is less than 2 days. And the average BMI for us is about 47. It's anywhere from 35 to as high as 80, 89. So what are the results that we have here at the University of Florida over a 5-year follow-up? So when we look at why we do the surgery, the reason we do the surgery is not only for you to lose weight, but also to help you with a lot of the comorbidities that some patients have. So when we look at our patients that have undergone bariatric surgery, specifically the laparoscopic Roux gastric bypass and the laparoscopic sleeve gastrectomy, we do note that diabetes completely resolved in 70% of patients, resolved or improved in about 90% of patients. Patients that had hyperlipidemia, they had about a 70% resolve or improvement in their hyperlipidemia. The same thing for hypertension. 54% of those patients resolved their hypertension, and about 76% of them resolved or improved their hypertension. Sleep apnea is resolved in about 83% of patients, which the patients may not care, but their significant others considerably love the fact that they're no longer sleeping next to somebody with a sleep apnea machine. And depression has improved in about 35% of patients. Not to mention that urinary incontinence is also resolved in about 2/3 of the patients. So when we look at bariatric surgery volume by the top volume hospitals between 2009 to 2010, we're the 5th busiest hospital, and our volumes are growing. Obviously, these numbers change with the volume of patients that we see, but the most important thing is that we try to make our patients have the best experience here at the University of Florida. We are a bariatric center of excellence. And you could see we share with our patients all of our complications that we've had, and a lot of them are minimal complications. We've never had anybody die from gastric bypass. We've never had anybody leave the hospital with a leaking gastric bypass or a sleeve gastrectomy. When we perform the Roux gastric bypass or the sleeve gastrectomy, we take a significant amount of care to ensure that the staple line and the creation of the gastric pouch and the sleeve gastrectomy are perfect before the operation is ended, so that way we don't have to worry about any leaks post-operatively. Our length of stay, as I said earlier, is less than 2 days for most of these procedures that we form. You come in, for example, on a Monday, you'll be home by Wednesday. It does require significant involvement on the patient's part. We ask that the patients are active participants in their care. They are required to be up walking around the day of the surgery following their surgery. Again, they're able to do this because we perform all of these procedures through small little incisions. So to end, you have everything to gain by losing. Here at the University of Florida Weight Loss Surgery Center, we are a bariatric center of excellence, and we look forward to taking care of you and developing a long-lasting relationship. So thank you.